Okay, so it's already hour and 15 minutes. Let's get to the final presentation, which I am presenting. Usually, I reserve some presentation as regards to the structural case, and this is what I'm coming at. So, I'm lucky, fortunate of doing more structural cases. So, I'm trying to give you, uh, you know, fabric of how these structural cases we plan and do it. So in the end, again, I would say we keep learning from each other. The Rupesh case was absolutely mesmerizing. Okay, so mitral edge-to-edge repair, now having done almost 40 cases of mitral edge-to-edge repair with Mitraclip, I think our reflexes are getting better and better with each and every case. First 10 cases is a very good learning curve. You tend to be very slow, your reflexes are developing. But once you have done that, I think then you get the real essence, how to have a best result with mitral edge-to-edge repair with Mitraclip. We all know there are two types of MR where Mitraclip can be considered or planned. It's a primary degenerative MR, which is either a flail mitral valve leaflets, prolapsing mitral valve leaflets. So this is one area. And then we have a secondary functional MR because of tenting or tethering of the valve leaflets because of dilated annulus or dilated LV cavity. I think that is another area where it's secondary to ischemic cardiomyopathy or dilated cardiomyopathy. There is a gross MR. So these two MRs can be attempted with Mitraclip. For many heart failure patients with MR, maximally tolerated medical therapy may not be enough. And this was very evident with my last case, which I'll just take you through that. And we see many patients where either they are deteriorating in heart failure because of the MR status despite GDMT. I'm not saying there has to be absolute lifestyle modification things which we should execute in all these patients and then a full GDMT. And still, if these patients are not improving or deteriorating and their PA pressures are high, they are incapacitated because of MR, then those are the cases where we can think of planning mitral edge-to-edge repair. So in many cases, now these patients usually have a ejection fraction of 15, 20, 25%. So they are going to be very high morbidity and mortality in any surgical intervention. That is where the Mitraclip has a role. So this is a device, how it looks. We only have a Mitraclip as for now. We're not having Pascal. So this is how the procedure is planned: a transeptal puncture, steering and advancing the clip into the left atrium. And then to the line of coaptation, we have to make sure that our clips are absolutely perpendicular to the line of coaptation. And then we go into the LV, retract that clip, grasp both the leaflets again at a 90-degree, and then totally close the mitral clip arms. So this is how the procedure is done. I'm not showing you that video. I'll show the real life cases. We have a good trials, good data. Co-op trial showed that this is giving us a survival benefit as well as the heart failure admissions, hospitalizations decline. 4 generations of Mitraclip are available. This is how we plan. I think let's come to the cases. This is the fourth generation of Mitraclip, is a G4. G4 is the system which we are doing these days, and this is how it looks. G4 NT and NTW, and then XT and XTW. So XT and XTW are longer arms, and then also it is wider. So NT is 4 millimeter wide, and length is 9 millimeter, and and NT is 4 millimeter, 9 millimeter, NTW is 6 millimeter, 9 millimeter, and then G4 XT is again you know uh, 4 millimeter and 12 millimeter in length, 4 millimeter width and 12 millimeter in length, and XTW is 6 and 12. So these are the available stuff, and this is how it looks like, all the console. And then there are grippers. Both grippers are lowered that grasp the leaflet once they are in position, and then we confirm it is all a T guided procedure. The T uh, tea companion of yours has to be very, very intelligent and astute, and that is actually a very good teamwork. This is how it is done. Look, the grippers are down. Now it is catching. Now grippers are not down. Grippers are open. And then once we close the gripper, this is a 60-degree angle. This catch hold of a leaflet and then we close it. So this is all the things which we check. And I think this is more of theoretical thing, but animations, but I'll show you the case. So this is one case where I did Mitraclip in 77-year-old male patient with degenerative MR, where anterior leaflet was flail at A3. Now, once we are talking of a degenerative MR, the flail component can be anywhere. So this was a A3 flail. Now, this is not easy. Only thing is one has to have a good experience and learning curve with almost 15-20 cases before really attempting these complex uh, procedures in these complex subsets. Patient had undergone a CABG 22 years back with surgical high risk and multiple comorbidities. Look at this. So this was the MR. Look at the flail A3, grade 3 plus MR. And this is a 3D picture. Now this also tells, look at the flail part. It is visible. I think you can decipher. If you see clearly, there is one component of the anterior mitral leaflet which is flailing into the LA and causing this MR. That is A3 component. So now we know we need to catch hold. So we are back. So sorry, interatrial septal puncture is the key point, and that has to be very precise. And then after that, this is a big sheath which enters from RA to LA. And after having established on transesophageal echo that we have a sheath mouth in LA, and then we remove all this dilator, and so then we remove the dilator and the wire from the LA. This is the second video is showing it is dilate, it's being taken back. And now this sheath is there. What I was trying to tell that, now sheath point is this, at this point, which is in the LA. And then this is a clip delivery system, CDS. Now this trajectory is very, very important. This trajectory we only get if we have a precise puncture and a good height. In the four chamber view from the mitral annulus or from the line of coaptation, at least it has to be 4 centimeter above. If it is not, we will face problems. There are many rotations possible on the console of the Mitraclip, but still it has to be a good puncture. And then now see, we have entered this LA, and this clip is the clip arms are open. So these clip arms we check before really diving into the LV. These clip arms should be in fluoroscopy. This is slightly almost a AP view. Uh, Slight LAO. This tells this should be the direction. Clip arms should be like this. Then usually it is perpendicular, but it has to be checked in 3D and NFOS view from the transesophageal echo. If it is totally perpendicular, 6 and 12 position, then we dive. After diving into the LV, we keep checking that orientation of the clip should not change, because sometimes while we dive from LA to LB, the orientation changes and we again have to clockwise or counterclockwise rotations. We have to make the orientation of the clip arms perpendicular to the line of coaptation. And once we have done that, then we start retracting this mitra clip open arms back so that both the AML and PML falls on the clip arms. And then we start, we get the grippers down, and then we start closing the clip. This is how this is done. So I think this case will show you a better detail. Probably those videos were not fully showing the orientation. So this is a recent case which I've done last month. This case, a young lawyer, almost 53-year-old. No, sorry, this is a separate case. 53-year-old female, functional MR, non-coaptation of A2P2 and lateral side of A2P2 level of the mitral valve. Patient was on CKD on dialysis, posted for renal transplant, multiple comorbidities. This is the MR etiology. Look at this, a significant MR. A2, P2, and slightly lateral to A2, P2. There are two jets. In this view, it looks like two jets, but actually this is almost a central jet. So this is how it looks. And see, this is the coaptation point. And then this is septal puncture height. As I was saying, the septal puncture height, the precise septal puncture is very, very important. And then we have, this is the septal puncture being done. The tenting is there. And this tenting, while we haven't punctured, at this point, we check. Now, this is first video is a bi-cable view. So bi-cable view, it should be central almost. Look at this. And then this is another view where aorta is visible, aortic valve is visible. To see, it should be posterior. It should be away from the aorta. So these are the 2 points where we decide how a good septal puncture is done. This is bi-cable view. It should be in the fossa vallis, but then it should be posterior, in the other view. And then this is a Mitraclip alignment in the 3D and FOSS view. Look what I was saying. So this is a tilted Mitraclip. This is almost at 7 and 1 position, 1 o'clock and 7 o'clock. This is not what we want. We want a perpendicular, 12 and 6 position. On the upper side is, this is aorta, this is anterior, and this is not perpendicular. So it requires a further movements, counterclockwise or a clockwise rotation to get the clip oriented. And then once we have a perpendicular position, we dive down, and then we retract it back in the LVOT view. This is almost a LVOT view. Grasping should be done in a LVOT view, and then we get the grippers down and close the clip. Now look, there was a significant MR to start with, and after we have closed, the MR has totally erased. So this is a very, this is how we plan a Mitraclip case. There is one case which I think I couldn't see it myself. I gave it to my associate, but I think one case is still missing, which I'll show you some other time. I've done a recent case almost 20 days back. This was a lawyer who had inferior wall MI, posterior wall MI, and RCA, L6 territory is totally akinetic. And the guy has been totally symptomatic with a severe MR, 30% EF with severe MR. And he tells that I can't even walk 5 to 10 steps. I'm too disturbed, very torrential MR. And we got a very good result. So now he's saying that feeling of breathlessness is totally gone. So I think it's slightly incomplete, but I'll have a better slides to show you how it is done. Now, one thing I'm showing you here, this is a 3D NFOS view. And see, we need to rotate it counterclockwise to make it 12 and 6, and then dive. And even after diving, we keep checking this orientation. It should be again perpendicular. Retract the clip back so that both the AML and PML falls on the open arms of the clip. That has to be checked in a LVOT view. And then once we are getting that, we get the grippers down and start closing the clip. And this is how it is. It looks like. Now, another thing which is very important, which your T companion tells you, that how much grasp of AML and PML is there. How it is done? They calculate the length of AML and PML prior to the grasp and then after the grasp, and deduct from the total length this length available. So that tells you that how much bite it has taken on the AML and PML. It has to be at least 5 millimeter or so, otherwise there are chances that single leaf detachment can happen. So this is a beautiful procedure in the select cases, although cost is little bit of constraint still. Not many people can get it done, but once the patient is highly symptomatic with severe MR and is high risk for any surgery, I think this is the procedure to be attempted. Thank you. And this is, sorry for little hiccup. There was some lag in between, but otherwise this was a beautiful session. I thoroughly enjoyed it. And, before we really conclude and announce the best presenter, which I think we don't have a doubt in our mind today, but I am personally inviting everybody of you For 23rd and 24th August, we are having another session, another round of IC Summit 2025 this time, and we are definitely making it more interactive. I'll also put a message on our Academy group. Please give us the inputs how we can make it better, how we can make it more interactive and knowledgeable. So I don't want to make it a show where it is all planned by me. I think let's all join hands to make a family and give your inputs. I'll ask for
Apathy.
all of your inputs. And so please block these dates, 23rd, 24th August, Saturday and Sunday in Gurgaon. The work will start now and we'll be sending you all the invites. And in fact, I'm also thinking it's being planned that we will create a IC LIs. All active Academy partners will be IC LIs, and you will have a more stronger role and contribution to make the program more robust. So thank you very much for the today's session. It was very good. Any of the comments on any questions from Mitraclip? I think we discuss for 1 or 2 minutes and then call it a day. Anyone, Rupesh, Karthikeyan, you need to.
I just sort of wanted to ask about like, is there how stringent are you on this area of mitral wall area? Once had a patient in whom the mitral wall area was slightly less than 4, then we dropped the idea of flip.
I think, yeah, this is
So,
very important. Even we have refuted and denied Mitraclips to certain patients, but we do so once it is less than 3.5. So if it
okay,
is 3.5 to 4, we still go ahead and do that. Uh, less than 3.5, we have done two patients with 3.2, 3.3 MVA. In one patient, the gradients went up to say from the initial gradients were around 3 millimeter, but then it went up to 7, 8 millimeter. And then we kept on changing the position, but still we could end up the procedure at 6 or 7. That was one case. And after that, we made sure that less than 3.5, if we can deny and pay, we can do something else. I think we tend to do that. But the comfortable zone is 4 or more, but 3.7, 3.8, one can still attempt, and usually gradients do not go up. Obviously, it depends on other stuff also. How is the mobility of the PML? Is it too rigid, too tethered, too fixed? You know, that also decides. And where exactly are you taking a bite? If it is central A to P2, then the two lateral compartments, medial lateral compartment will give the adequate flow across the mitral valve and gradients do not go up. So it all depends. Also, one more thing we can choose rather than XTW. XTW is a wider and more lengthier. You can have another NT. NT is leaner and less wider. So if you can have that clip, the gradients will be better after the mitral clip. So all these things come as a reflex after 2025 cases. But these are important things. So 4 is, I would say, a area more than 4 is ideal. 3.6 to 4 is a moderate level where according to anatomy you can consider, but less than 3.5 one should not plan it.